Hey, I'm Kathryn Walker, go by Katie. I'm here today to talk about one of my favorite things in life right now, ketamine. Talking about this because the whole world of the brain is changing, if you know it or if you don't know it, and thank goodness, since we're in a mental health and pain crisis across the entire world. Here to talk today about ketamine. We'll be going over a presentation, and the goal of this is to help to give additional information in this field, right? So a little bit about me. I've been a nurse for about 20 years. I have two additional degrees, one in anesthesia to where I practiced all specialties. I've been practicing anesthesia since 2011. And then I got my psychiatry degree as well. So I'm a psychiatric nurse practitioner. But my specialty is ketamine. So I've been around maybe 15,000 people between my lifespan, I guess. And youngest person I've been around with ketamine was 12, who had coexisting homicidality, suicidality. Oldest we've had is 92, complex grief. So today, this presentation is going to be very scientific, but I'm also going to throw in additional pieces to where it should be absorbed and heard across the spectrum of. So the goal with this is that we help to increase information, right? So you don't have to be around 15,000 people in order to hear what I've learned. So I'm here to try to share some of this stuff with you because it's a very new evolving field. And ketamine and psychedelics are going to be something that are going to hopefully change the world. They can definitely do it. They are looking at the brain from a root cause analysis, not from necessarily just the re-regulation of symptoms. So they're getting down to actually breaking the cycle before the cycle starts instead of just treating the cycle, hoping it goes away. So really cool neuroscience with this aspect. So doing this today, again, I do this presentation to give overall arching views. Ketamine, psychedelics are very complex. They're very, very new, and they're changing the way we look at things. So, should you need additional information, I'm happy to meet with people, either personally, professionally, whatever, right? Because we not only do we need to learn to take care of ourselves, we need to learn how recognizing that we're all on a similar level, a similar spectrum throughout our growth lifespan. Um, that we should respect that, right? Because in the States, we're told to, all or none. We're told you're wired to be an addict. We're told, oh, mental health's in your genetic deficiencies. We're told, all this stuff, right? So we're actually seeing that we actually have a lot more control than what we're being told. And we're seeing that psychedelics is helping to auto-regulate a lot of these pieces, which is causing regulation of chemical imbalances and all this lovely stuff. So that's my little intro. I'll try to stay with the presentation as much as I can, but I'm also going to throw in tidbits because I think that stuff is very necessary. So ketamine, the great disruptor. So disruptor, me personally, when I heard disruptor, I take that as negative. But disruptor is, something that just comes into the system and allows us to start looking at things differently. Ketamine definitely does that. Everything that I've learned in nursing school and anesthesia school, and then the psychiatry aspects as well, none of this, zero was mentioned, right? And I went to school for 11 years. So none of this was mentioned. I've learned all of this boots on the ground, and then going to neurologic conferences, as well as psychedelic conferences, as well as psychiatric conferences, as well as pain conferences, as well as anesthesia conferences. All of these things are integrating and aligning. So we need to utilize our specialties as a provider anywhere, right? General practitioners, OBGYNs, neurology, orthopedics, cardiology. We're seeing that it's actually decreasing, right? Your cardiac resistance over time. So ketamine maintains your cardiac resistance, which is great. But over time, it decreases a lot of those people who have just chronic hypertension because they're just working to where their sympathetic nervous system is so overstimulated all the time. Constant catecholamines are coming out, which is causing all this, concentric systems aspects to where ketamine is decreasing that stress load and it's allowing our vascular system to actually regulate a little bit. So pretty neat stuff. So ketamine, with this, we always want to look at the risks as well as the benefits with everything, not just looking at the benefits first, but look at the risks first and then consider the benefits. But then also what we do in society is, I feel like as medical people, we get scared. We get scared of liability. We get scared of what if they take my license? We get scared of what if I get sued? And you know what? we need to really alter our thoughts on that, because the CDC is now seeing that the intimidation that we have in the field of medicine is actually causing harm because we're not getting in to actually help these people on the level that they need help. But then again, our tools are limited, right? So we've all kind of been burdened by the opioid crisis. Well, now here comes psychedelics, known history of abuse, right, with psychedelics, but we're going to go over all this stuff so there's more clarity. But we just need to be very well aware of what's going on, how to auto regulate, how to monitor our clients. So ketamine, go through the timeline here. In 1956, PCP, if you know PCP, it's angel dust, was actually being utilized in the anesthetic world. Prior to PCP, our anesthetics were either combustible, that's why you see ORs like away from the hospital or on the top level. So those are your older ORs, because they used to be explosive. They also used to cause liver damage or seizures. So PCP came around, they saw it had some anesthetic-like qualities, side effects, horrible, adverse events, bad, huge hallucinogenic. So they took PCP back to the lab and they derived ketamine from it. So ketamine is a third line cousin to PCP. It is 1/10 to 1/50th of the strength, depending on your sources that you're looking at. But ketamine is a dissociative agent at a low dose. And it can be even lower actually than that and not cause dissociation. Or it can get high doses. It can cause hallucinations. So what's the difference? When you say psychedelic is mind altering, right? Your psychedelics are going to be ketamine, LSD, MDMA, psilocybin, 5-MeO, ibogaine, ayahuasca. Ketamine is going to work on the glutaminergic pathways more so. Psilocybin works on the serotonergic pathways. MDMA is ecstasy, and they're looking at MDMA from a PTSD standpoint. LSD is actually also derived from a mushroom I just found out called ergot. But LSD, they're actually having a lot of success with that for anxiety. 5-MeO comes from a little frog, a poisonous frog, and it's apparently very quick on, very quick off. Great benefits, but I really don't know too much about 5-MeO. You've got DMT, which is kind of along those categories as well. But then ibogaine, ayahuasca, you're going to hear a lot about them because there's a lot of research going on with ibogaine and ayahuasca specifically for addiction. So we're seeing that all of these guys are looking not only at addiction, but mental health, pain, neurodegenerative aspects. So ketamine, 1956, kind of came from PCP's baby. 1970 was when ketamine received its approval as an FDA drug, and it was first utilized in Vietnam. It's called a battlefield anesthetic. It is its only drug in its class called a dissociative anesthetic. So if you look at pharmacology quite often, psychedelics actually have not been classified in traditional pharmacology yet. So that will eventually get there too. But right now we're just in this, kind of amazingly cool transition period where the old's coming in with the new. And it's going to take a second because these drugs are not meant to be utilized like we do with traditional medications. They have a very unique specialty. So history of ketamine, you see in 1970s, FDA approved, 1980s, it started becoming, kind of utilized as the party drug in an illegal capacity. In the 1970s, Richard Nixon, that was when he did the, against psychedelics, made them all illegal. Even though there was really good data behind a lot of the psychedelics, there was a huge amount of misuse, miseducation, abuse with psychedelics. And you have to think, a lot of our education now comes from social media, and we didn't have that back in the 1970s. So we weren't able to help educate. But fortunately, we have this widespread aspect now to where we can educate much more effectively. So when they did this in the 1970s, it was a huge hit to a lot of people, unfortunately, but things happen. But one of your most recognized organizations called AA, Alcoholics Anonymous, was actually created under the use of psychedelics. So the creator, Bill W., Bill Wilson, I believe, um, actually did LSD for his alcoholism, and he helped to create AA under LSD. So there's a lot of really cool stuff. So their number one abstinence program, congratulations, was based on psychedelics. So we'll hop down here, 1999, ketamine became a Schedule 3 non-narcotic with the DEA. Um, and we've been using it for a very long time. It's utilized across the lifespan. So we use it with moms who are having C-sections. We use it for children who need lab draws. Using animal medicine, you'll hear it called a horse tranquilizer. Reason being is because it helps to maintain cardiac and respiratory resistance. So it's actually safe for our little furry friends. You could overdose little guys, and their heart rate will become elevated, and their respirations will become elevated, much unlike opiates, right? It doesn't suppress your cardiac and your respiratory function. So that's, something to be aware of. But, with everything, like I said, there's risk and benefits. So when you're looking at addiction with ketamine, ketamine does not work in the same capacity of addiction as opiates. Opiates actually cause upregulation. You need more drug for those receptors that are being created. Ketamine actually causes downregulation of these receptors. So when you take ketamine, it makes other medications more effective, which is great from a prescriptive standpoint because you can start decreasing opiates, benzos, all your SSRIs, SNRIs, TCAs. You can start decreasing those because they are becoming more effective at higher doses when people are having ketamine. Because what ketamine's doing is it's making new receptors in the brain that aren't addicted to these old substances. So I know with addiction, we like to kind of utilize that word. But if you're taking a medication daily and you don't take it and you start having withdrawal effects, your brain's addicted to that drug. That's the way we should look at addiction, not that you're addicted to a substance. And, when we isolate all these people with that addiction, if your brain needs something, it's not you consciously choosing that addiction, but your receptors need that drug. That's why there's, a lot of these withdrawal effects that come from mental health medications. So ketamine actually helps to decrease that. They're using it with detox as well because it's making new receptors. These little guys don't know what you've been taking in the past. And that's why it's able to compensate much more quickly. So 1999, Yale University made this amazing discovery. Ketamine causes the brain to regenerate when prescribed in appropriate quantities and quality aspects, right? So you cannot take ketamine every day and expect that your brain's going to do better. It's not, because you're not stimulating this organic process. We want to use just enough medication to create an intervention in the brain to where the brain organically fixes itself. And that's what we're going to talk about. So Yale University's accidental discovery of ketamine came with them looking for a treatment for schizophrenia. And with schizophrenia, they were trying to give so much ketamine to where little rodents looked like they were altered, schizophrenic aspects. And they saw the little guys were actually becoming less depressed. So when they saw that, that was when they started following it. When they started following it, the neat thing is mental health became real. It's data. It was, so it was like seeing it on MRIs, seeing on PET scans. We started seeing that wow, like look at this one infusion is actually changing the way the brain is causing new growth. Who knew? So now we know instead of, all those old, if you still believe this way, your thought processes should change. But you only make brain cells until you're 26. And if you drink too much, you're going to lose a brain cell and they never come back. Wrong. If what else? You're wired to be an addict. First time you take a drink, that was when you knew you were an addict. Wrong. That's not true either. But ketamine allowed us to see all these beautiful terms called brain plasticity, regeneration, neuroregeneration, all these things. So when in the right context, we can cause our brain to regenerate. Amazing. Thank you, ketamine. Thank you, psychedelics. Now let's learn how not to mess up the system like we did with opiates. So history of ketamine here. So Carlos Zarate, you can see in 2006, he was one of the biggest guys with ketamine, who was kind of the godfather who helped with this. So he really took it and ran with it and really has opened up literally a whole nother world as to how we look at the brain. So you'll see here on this slide here, ketamine papers, how they have greatly changed. I'm not moving myself. I think I can. So the ketamine papers, you can see, sorry, my face is in the way. But it goes from, 1968 to 2020. So you can see how this is jumping tremendously, and it's even jumping even more now, right? So the VA actually covers ketamine infusions for our veterans. They've been doing that since 2017. Most people who work at the VA don't know that ketamine is being offered, and they think that it's completely crazy. So we had to send them their protocols to let them know that they do cover it, and veterans do great with ketamine. So yeah, so it's a growing piece. There's insurance companies out there that are covering ketamine infusions for employees working with their employers. So if you ever, if you have interest with that, just give me a call. I can get you connected to whomever, because I'm kind of in the space. So let's go to the anatomical pieces with ketamine. So this is your medial prefrontal cortex, the hub for multiple signaling pathways, emotional processing, and stress response. So this is really a primary piece from psychological understandings. I know right now we think that it's very, very important to look at trauma and or childhood trauma and trauma as to how we react. But what we're seeing now is those are only a couple pieces that add to the overall picture. And the reason being is because of the way that they acutely stress the sympathetic nervous system. So your prefrontal cortex is where a lot of this stuff takes place, and it will get stuck. So what happens, what we're seeing is that the brain actually has, when data comes in, how does your brain process the data? So we're seeing that chemical imbalances actually are not leading mental illness. Something causes our brain to eventually have chemical imbalances. So there's something called your salience network. Your salience network, if you don't know about it, you should read about it. But your salience network talks about, like, when data comes in, what does your brain do with it? Does it hyperinflate the response? Does it hypoinflate the response, or does it remain neutral? And over time, your brain will just duplicate what it knows. Like our brains, I tell people all the time, our brains are not eclectic. They are very complex to make them look eclectic. But when data comes in, a healthy brain can acknowledge the situation and acknowledge the emotion that you feel. A brain that's been overstimulated with stress will enmesh those. And that enmeshment is where the memory and the emotion gets enmeshed. So that's when we feel triggers. That's when we feel emotional dysregularities. That's when we yell, we're short-tempered, we don't know why we acted like that, all these things, right? So I'll tell people, if you're emotionally led for anything, you should look at getting help. You should look into psychedelics, right? And there's a lot of different opportunities across the world for people who, who have this, right? So no matter the regulations, whatever state, country you're in, there are options, but also you have to understand there needs to be additional support in all of those options that we seek. So when emotions come in, what do you do with them? And that's a big piece. So if you have three people, you tell them three people the same statement, they're all three going to have a different reaction. And they're going to have a different reaction based upon their past to their present reaction, right? That is what their brain knows. So we duplicate what we know from experiences that we've learned. And with this specifically, when people, so if you think about trauma, like PTSD aspects, when things come in, what does the brain do with it? So think about PTSD or PTS or trauma, whatever you want to call it, right? Think about a stimulation, an overstimulation or stimulation that causes too much of something. When this data comes in, our brain will react to it if it feels that it's a threat. So it doesn't matter if it happened yesterday or 35 years ago. Quantum physics has shown us that our brain does not understand time. Time comes in planes. It does not come around a clock, right, that we see every day. And that's why we actually have clocks and phones and sundials, because our brain does not understand time. So a lot of times when data comes in, what does your brain do with it? If it has a negative response, it's going to duplicate a negative response. If it has a positive response, it's going to duplicate a positive response. If it has too much of an abstract response to where you're having schizoaffective symptoms or schizophrenia, it's going to duplicate that. If you're having too many concentric thoughts to where you have more OCD and you have to control everything, it's going to do that. The neat thing with psychedelics they take the brain to a neutral space, and they really, really work on when the brain's in that neutral space, it works on this medial frontal prefrontal cortex. And what it does is it allows the brain to be categorical again. So that enmeshment of, why do I feel like this? Why do I have all this pressure? I don't know what's wrong with me. I'm foggy. I can't even put a thought together, or I can't turn my brain off. All right, it's at two ends of the spectrum. When this data comes in, when it fragments it, the fragmentation allows us to not be emotionally connected to it, and we can be analytical and view the emotion as well as the situation. So when we view those two things, that's when we can start increasing our coping mechanisms, because we're not having an overreaction of the sympathetic nervous system making we feel we're being threatened. We're instead able to look at non-objective data that's allowing us to effectively integrate, recognize, build coping mechanisms that are actually to our benefit, not to our demise. So, long story short, medial prefrontal cortex, very important in this. And you'll see with this, there's a lot of data in this presentation. Feel free to keep the data or whatever you want to do, and go over it, because I'm not going to go over everything to this extent, or we'll be here for 12 days. Your hippocampus is another important piece, right? So it's involved in learning and memory formation, the consolidation of memories from short-term to long-term to cortical memory storage, for the role in negative feedback inhibition. So with this piece, right, we're seeing the hippocampus as well as the amygdala to have really big a really big impact. So what we want, and this is what psychedelics allow us to do, once we can see that data, this is what talk therapists try to get you to do. They try to get you to view it from a third party perspective, right? So you don't have that emotional overconnection or the memory, or, it's just nastiness. So when the amygdala is able to allow us to look at how do we process this stuff, the amygdala will help it to go from short-term memory in your prefrontal cortex to your long-term memory. When this data is in your long-term memory, you don't feel the emotional lead of it. Instead, you can bring the memory up. You can choose to bring the memory or the emotion if you want to, but the emotion doesn't lead the context. So if you feel angry, rage, anxiety, depression, whatever, dissociation, avoidance, isolation, if you're like, why am I doing this? Recognize it's probably an emotional response. If it's an emotional response, you need to get help, because the brain will keep duplicating what it knows and it will not get better. And these medications that we get put on for all this piece, it suppresses it. When it suppresses it, it's fine if you're able to have that third party view to where you can actually increase your coping mechanism, so you don't have to be on all these medications for the rest of your life. Because if you do know, a lot of antidepressants are only meant to be taken for 90 days, no more than 90 days, because there's not data out there that actually shows its long-term benefits. So why do we put people on antidepressants for decades? Because it's the only option we have. Well, here's other options. So, so your hippocampus, you can see here, it's involved in learning and memory formation. It learns from your past. It does not learn from your future. It worries about your future, but that's a control base, right? That's anxiety. That has nothing to do with anything. It's actually, when we create anxiety, we're creating a false narrative of comfort for our brain, because we're trying to control the future that we have no control over. So the only thing we have control over is the present. Nobody teaches us how to be in the present in life. Nobody teaches us how to be peaceful and calm. We learn meditation. Some people are learning meditation for the first time in their life in their 70s. We're learning how to be peaceful and calm. Nobody teaches this from a childhood standpoint. If we grow up in a traumatic mindset, our brain is used to chaos. It doesn't know how to be calm, because it doesn't feel like it can be vulnerable enough to be calm. So these are all techniques we have to learn, right? Because the goal is that you don't control everything. If you're trying to over control everything, you're not doing well. And because over control is actually a symptom of mental health. So people are like, oh, I'm so detailed in my control. Yeah, you're struggling with your mental health because you feel out of control in life and you're trying to over control everything to maintain a neutral balance in your brain. The goal is that you feel empowered in who you are, and you feel aligned with who you are. And you can sit and you can take things in and you can look at them from an objective mindset, and then you can choose your next decision. If you feel like life is always everywhere all the time and you're just, it's too much. I got kids, I got work, I got all this, I can't sleep, I can't, I got to clean the house, I got to do all this. It's too much. It's too much. So you're hyperinflating, all this data coming in from your Salence network to where you feel a hyper excitable response coming in, and your brain will continue to duplicate that. So that is something that we have to be aware of. When we're aware of this, that's when we can learn. That's when we effectively address the mental health crisis. So hippocampus. And now I can actually see what I was reading. Involved in learning and memory formation, consolidation of memories from short-term to cortical memory storage for the long term. And then there is a role in negative feedback, which inhibits the glucocorticoids that we have in our system. Your thalamus, we won't talk too much about the thalamus, is the major hub between the cortical and subcortical regions. It is the critical connection between the amygdala, though, and the prefrontal cortex. And it transmits neural impulses from the peripheral receptors to the cerebral cortex. Amygdala, like I said earlier, this little guy's your processor. So when data comes in, it does drive a fight, flight, or freeze response. It helps to regulate emotions. It assigns feelings to experiences when forming memories. And it also helps to create dread about perceived fearful situations, which may trigger a chronic role in chronic anxiety, which is conditioning. So conditioning is something we need to be very well aware of. So conditioning is your brain duplicates what it knows, just like muscle memory. So everybody thinks we have muscle memory. We don't have muscle memory. Our brain actually remembers what the physical piece is. Only thing that our muscles do, they contract, they relax. That's all little guys do. But your brain also has behavioral memory. So the brain will duplicate what it knows based on how it's been conditioned and or trained. So you don't train your brain. The world trains it for you. So data came out and said 5% of the decisions that we make in life are based on our conscious thoughts. 95% is based on your subconscious. So conscious thoughts are choice. Voluntary choice. It's conscious. Subconscious, reactive choice. Or reactive decisions. So consciousness, voluntary choice is, what am I going to wear today? What am I going to buy at the grocery store? Where am I going to go on vacation? Those are more conscious. Subconscious is more reactions. So when you yell, when you scream, when you walk away, when you don't know why you acted that way, that's not you consciously choosing that. That's an involuntary action, and that's your subconscious, which is 95%. So our goal with this, right, with psychedelics and ketamine, is that we learn to not only understand our conscious patterns, but it's our subconscious patterns. And the data, or not the data, the definitions with subconscious, not even there yet, right? So we'll get there. But the levels of consciousness that I learned in anesthesia, completely different than these levels of consciousness. And when you look at different levels of consciousness, like your conscious state is going to be different when you're getting a massage versus it when you're fighting in a cage at the UFC. You're going to be, having a whole bunch of different catecholamines and sympathetic nervous system responses and all this other stuff. They're all going to be different, right? That's the way we should start looking at consciousness. Because when people are in these reactive mindsets, when they've grown up in a chaotic environment, that's all their brain knows. It's constant chaos, and they don't know how to break it. They literally don't know how to. If we can show the brain what peace and calm look like, the brain can then start duplicating that. And that's the goal. So the goal is that we show the brain, here's your root cause. Then we can look at medication management with all the other pieces. But these medicines are not intended to go to the root cause. They're only intended to treat the symptomatology, which doesn't help when the brain's duplicating what it knows underneath. That's why medications eventually stop working, because we're just pouring a cup of water in the ocean. We need to learn how to actually, make new pathways so we're not constantly getting flooded. So that's where psychedelics and ketamine come in. Your striatum here, it talks a little bit about it. We won't talk too much, but coordinates multiple aspects of cognition, including both motor and action planning, decision-making, motivation, reinforcement, and reward perception. Your anterior cingulate cortex, your ACC, is involved with complex cognitive functions such as empathy, impulse control, emotion, and decision-making. Your Dorsal Ralph nucleus is the major source of your neuromodulators. So serotonin, substance P, catecholamines, all the guys that are involved. Yes, they're involved with mental health, but they're also involved with stress response, and they're also involved with pain. So they actually contains about the DRN contains about 85% of your serotonin receptors in the brain, which may also influence circadian rhythms. So another thing here with circadian rhythms is insomnia. Insomnia is a big telltale sign. So if you want to talk about suicidality, um, when you're looking at that, your people that are going to be at highest risk for suicide are going to be the people that are struggling with their mental health and they're not sleeping. Once they stop sleeping, they're at increased risk because everything gets kind of combined. They're tired. They're sleep deprived. They can't make a normal emotion. They can't make a normal thought. They're foggy. It's almost like they're living in this abstract world, right? So death doesn't feel like it's that bad of a thing because they're trying to escape what they're in. So once you see clients who have any type of, better off dead feelings, suicidal ideations, and if their sleep starts messing up, those are the people you should look at referring to ketamine sooner rather than later, if you want to try to decrease their loss of life. Um, but yeah, so people who have insomnia, those are people who will over time, they will develop mental health issues because their brain is not getting the level of productivity that it needs in recovery at nighttime. So here's some basic neural anatomy here. So you can see, I'm not going to go over all of this, but you can see these little guys. They're very, very important in psychedelics and in mental health and in pain and neurodegeneration. But your dendrites are one of my favorite things to talk about. So these little guys, when your cells duplicate like once every 30 days, when they duplicate, are they duplicating in the stress environment and inflamed environment? Because if they are, they're not going to be as healthy. So your dendritic spines here, they're very plastic, meaning that they can change in shape. So they either get better or worse. They do not remain constant. So your dendrites, you can see on the left side here, dendrites are kind of coming off of this little nerve cell here. And you can see the bigger guys are the healthier ones more so. The little guys are barely making it. On the right side, we just kind of show that kind of, more of the pathophysiology of that. So if that's something you want to look into, feel free. So your neurotrophins associated with neuronal function, here on this slide, we're talking about BDNF as well as VEGF. BDNF is the one I'm going to focus on more so. It's very important right now in psychedelic medicine. I'm sure it will change over time because all these things are evolving. But BDNF is stimulated by glutamate production through your NMDA receptors. So BDNF, it's a member of the nerve growth factor family, highly expressed in the neurotrophic factor in the brain. And it's regulated by gene expression and activity stimulated release at the synapses. It also helps to maintain normal dendrite and spine integrity. So we're seeing this, right? So you got your spinal column, you've got your dermatones, you've got all your pain aspects. So when we talk about mental health, pain, neurodegeneration, why do we think those three things are connected? They're all three treated very, very differently. The reason we think that these guys are connected is because we're seeing that your mental health aspects are living in a state of inflammation. Your spinal column is connected to your cerebral, right? So all those guys are together. Your cerebral function is connected directly to your spinal column. Spinal column is where we have a lot of these pain receptors come out. And then also with neurodegeneration, we're seeing that with degeneration, a lot of times you've got inflammation, you've got people who are losing function of their extremities and or their visceral, right? So people who have a lot of this stuff going on, they have a lot of GI issues as well. To where right now we're like, oh, we'll do an endoscopy. Here's an EGD, here's a colonoscopy. Everything looks good. Don't know what's wrong with you. Guess it's IBS. No, it's stimulation coming from the cerebral cortex. So it's the same way with pain. I don't know why you're hurting. Let's take you back to the OR. Let's just do it. Let's just open it up and see what we've got going on. Everything looks great. Don't know what's wrong with you. Anatomically, you look fine. It's not an anatomical issue. It's the brain sending out negative symptoms that are causing physical symptoms. So with the neurodegeneration, a lot of things that cause degeneration sometimes are the amino acids, which cause the protein clumping, which eventually over time can cause the plaques build up, right? So we're seeing that actually all psychedelics are showing some type of actually reversal of this. We don't know why, but it's dissolving plaques, protein clumps, and all this other piece. The issue is we don't know how to continually support all these people all the time. So we can do the intervention, but there's not, we still will probably need medications over time with these, but we got to do the intervention first. You don't do the intervention last. You do it first, and then you figure out what canvas you're dealing with. Right now, we're trying to treat the canvas, and we don't even know what we're dealing with. So that's the piece to where you want to try to stimulate BDNF because you can get more of a clear picture to where you become more of an effective provider with your outcomes. So here's additional neurotrophins associated with neuronal function. Glutamate. Glutamate's pretty fascinating. If you've not read a lot about glutamate, you should. It's over, they believe it's over 90% of our neurotransmitters in our brain, and it's called the mother communicator. So it's the major excitatory transmitter in the brain. It controls rapid and long-term synaptic plasticity. Its actions are mediated by glutamate inotropic receptors, which are required for regulation of number and function of the spine synapses. So you got AMPA, and then you got NMDA, which is where ketamine will go and work on the NMDA aspects. You also have these two little guys here. We won't go over them really, but the mammalian target of rapamycin complex, and then the tropomyosin receptor kinase B. These guys help to also go, right? But with psychedelics, you've got primary, you've got secondary, you've got tertiary, and you've got everything else. So you've got all these different phases. But the biggest piece here, right? If you really want to look at really cool education with yourself with ketamine and with psychedelics, look at like literally, you can write this down. Look at executive function, central executive function specifically. Look at something called the default mode network. Look at the salience network, look at glutamate, and look at BDNF. Those 5 things. Brain-derived neurotropic factors, glutamate, salience network, default mode network, central executive function network. Those 5 things will give you a very good insight as to how this neuroscience is changing and how where we want these psychedelics, because we're seeing the psychedelics are actually stimulating these primary systems. When these systems are primary stimulated, we can actually work with the person to where we can break all these, cause a lot of autoregulation. GSK3 is another guy who we won't go over this much, but he is another guy who also helps to support the whole system with BDNF and such. So here's your take-home message. Basically with this, neurocommunication changes result in abnormal signal processing. So let's throw chemical imbalances out the door and let's go to abnormal signal processing going forward. That'd be great. And then that way we can look at pain, mental health, all these things, because we're seeing that everybody likes to get cervical surgery, and everybody likes to get lumbar surgery for their lower back. We're actually seeing that a lot of these situations may be where you're holding your stress, where if you hold your stress in your shoulders, you hold your stress in your hips. Some people over time will start having abnormal pathways of signal processing that causes neuropathic changes in all of those signals. So a lot of times, when people get fusions of their cervical or their lumbar spine, doesn't help their pain. And it's obviously they look better, doesn't help their pain. It's because it's not coming from the anatomical issues. It's coming from the brain. So again, start over with this one. The neurocommunication, your take-home message, neurocommunication changes result in abnormal signal processing. You have decreased healthy processing capabilities. You have propensity for cyclical negative thought patterns. You have a decrease in higher executive functioning or problem solving. You have an increase in difficulty to sustain clear, cogent thought patterns. You have an increase in difficulty in escaping cyclical negative thought patterns, preventing maladaptive thought and behavior extinction. And all of this leads to a vicious cycle of cellular stress, impaired function, chronic neuroinflammation, which causes chronic progression or worsening of symptoms of everything I just mentioned with the brain. So this is going to give you a little, if you really want to jump into pathophysiology, we can go down this rabbit hole. But this just gives you a little a visual, right, as to what we talked about. So you can kind of see your NMDA receptors here and how the little guys are speaking to each other through their synaptic ability. But this just gives a little bit of insight with all of the different pieces of the neurotrophins we were talking about. Here, this one I was telling you, like with Yale, how they did scale, or they were able to do diagnostic imaging and to see some different pieces. This actually is one of the really cool aspects. You can see in your middle row here is a baseline brain, and you can see there's hypo, excitable regions. But after a ketamine session, you can see a lot of that looks much more autoregulated. So something to keep in mind. And this is one of my favorite pictures. I like this picture because it really breaks it down for clients to where they can see it as well. But here is neurotransmitter, and you are looking at a control, right? This is pre-ketamine and post-ketamine, one session. So if you look at the little guy here, picture him as an interstate. Look at your interstate, and you can see the interstate is very much so has holes in it, like potholes. Looks like nobody's maintained it in a while. And then your exit ramps look really bad. You've only got one really good exit ramp that's connected. Everybody else looks like there's a decrease in budget. So you see one little guy, and those little guys where you see the arrows at the top, those are dendrites. So those are what allow our nerve cells to communicate to each other. Below that, you can see this is after one ketamine session. And you can see all this new growth after one. So why does it work so fast? We don't know. We're still discovering that. But people, it's an amazing thing. So while they recommend it now for, treatment-resistant depression, it's one of those things, if you start seeing your decreased quality of life change, you should look into ketamine, because treatment-resistant depression has nothing to do with the increased rates of suicidality. And suicidality a lot of times is ineffective coping mechanisms or trying to escape the situation. So if you feel like your life is decreasing in quality, be preventative. Go seek somebody out, because we need to start looking at risk mitigation strategies instead of looking at treatment resistance, because treatment resistance clearly is not working, because suicide's up, everything's up, everything's up. We need to look at risk mitigation, expecting that all of us at some time are going to have mental health issues, and whether that's anxiety or increased stress or decreased sleep, whatever, right? It's life. You just have to be able to be aware of, you can have a higher quality of life. You can feel empowered in who you are instead of feeling like you're having to over control everything, and you're trying to over control everything. That's when you have demise of yourself. You have demise of relationships. You have demise of your not being the parent that you want to be, not being the kid that you want to be, not being the coworker that you want to be. If you start feeling any of that, reach out, right? And that's why things like this really work. They're an intervention. It's 2 to 3 weeks. 6 sessions, 2 to 3 weeks. So literally it's like 3, 6, 9 hours, right? 9 hours, and it will change your life, kind of thing. That's the cool piece. And that's what you need to keep in mind. So here's some pain stuff we can go over. So pain, again, we won't go over this too much because I really wanted us to focus on mental health, but we're also in a pain crisis. So unfortunately happens. So here's pathophysiology, chronic pain, and CRPS. So your CRPS is your complex regional pain syndrome that we talked about. You see that a lot with females. Men will get it too. Men have a little bit more of a different presentation that females do. And they're harder. Men are harder to try to figure out if it's CRPS. Women, it's kind of more by the book. But you can see here all the changes, right? So your normal acute pain circuit, you have your peripheral nociceptive neurons, that's with your afferent or your ascending signaling through your dorsal root. The dorsal horn goes to the brainstem, which goes to the thalamus, and then the cerebral cortex. So you can see here with pain, right? Of course, our spinal column is involved. You have somatosensory cortex. It decodes the nociceptor information, which is where the location of the pain is. And again, you can see, wow, if we're looking at data processing, we can see why this might be something that can be altered. The hypothalamus hypothalamus triggers a release of pain signal neuromodulators to help suppress signaling through the descending pathway. And then you see the signal modulation through the opioid peptides, norepinephrine, glycine, GABA, and then your serotonergic and estrogen. So you can see not only are neurotransmitters involved, but also hormones. So this just gives you an overall. We won't go too much in this because it can get very complex. So I'll take you back to anesthesia school. But you can see, the ascending pathways, and you can see the descending pathways, and it kind of shows you the route. So your somatosensory cortex has a lot of influence with pain. So I tell people all the time, if you have chronic pain goes to chronic mental health goes to chronic pain, and those two will feed each other, and that becomes your identity. You don't know how to get out of that world. Ketamine psychedelics will help you get out of that world, because you have to change your thought process. And if you don't know which way to change your thought process, then you're going to be stuck in your own world. So how do normal pain signals morph into chronic maladaptive cycling? Neuronal damage by disease or trauma causes an altered neuronal electrical activity, crosstalk between neurons, upregulation in NMDA Rs in the dorsal horn. Inflammation causes peripheral sensitization, and then sustained signaling in the absence of the noxious stimuli. The signals become susceptible to an increase or decrease modulation at any relay point. So you can see kind of that piece there, the dorsal root ganglion to the dorsal horn of the spinal column, goes to the brainstem, the thalamus, and the cortex. And vice versa, energy travels two ways. Segmental central sensitization, you have neuroplastic changes in the dorsal horn, prolongs the sustained pain signaling, which causes hypersensitization, and then you get an exaggerated response to the noxious benign stimuli, which causes allodynia or hyperalgesia. So over time, your pain's going to continue to get worse, and that's the central sensitization aspect. Central sensitization is if it's pain that doesn't make sense, your brain doesn't really understand why you're having pain here, it's going to keep sending signals to make it worse, because the data processing's off. And a lot of times it could be actually related to the sympathetic nervous system from that situation. It has nothing to do with your pain. It has more so to do with the situation around that, which is trauma, but that trauma can actually cause the pain to get worse. So we're just treating the pain now, right? Unfortunately, in anesthesia, we'll just go block it. Your finger hurting, we'll do a block around your finger. But a lot of this is coming from just abnormal signaling from the brain that needs to be reset. So this just gives you a little bit more of a visual showing these different pieces. And this will tell you, just how shingles actually can cause a lot of this neuropathic pain. So we do have to consider nerve damage, but you have nerve damage as well as inappropriate data signaling. So with the central sensitization, you have neuroplastic changes in the thalamus and the sensory cortex, and then you have spontaneous sustained magnified impulse signaling in response to peripheral stimuli. That gives continued sensations of pain in the absence of the actual noxious input. So fibromyalgia, depression, anxiety are now generated and recycled by the cerebral relay points. So meaning that the situations that's causing the pain is no longer there, but your brain's reacting to it like it is. Again, you have to break the root cause. And then again, this just gives you that picture again that shows it from that standpoint. This gives you another picture showing, with fibromyalgia, why is fibromyalgia more kind of a categorical sense, whereas, other people have chronic widespread pain to where wind hurts them. They can't wear certain clothing things, right? And it's not them, it's the brain is over exaggerated everything, causing the central sensitization to where everything is having a physical reaction to this. And then, when people get depressed or stressed or whatever else, you'll see an increase in low back pain, you'll see an increase in their neck pain. Those are just common areas. And unfortunately, we just kind of fix them through neurosurgery right now, or steroid injections. But we're not going to the chronic root cause. So complex regional pain syndrome, this is something big everybody should be aware of. There's type 1 and type 2. One comes from an injury, one just shows up. They're not sure why yet. So it's a multifactorial chronic pain condition that usually arises after a traumatic injury to soft tissues. You get autonomic dysfunction, neurogenic inflammation, and then changes in your CNS neuroplasticity. You have microvascular pathology, inflammation in the affected area, which can cause edema or ischemia. You also have peripheral and central sensitization, as we mentioned, and then motor cortex dysfunction, which can adversely affect proprioception, and can also experience essential tremors in the affected limb, myoclonus, as well as dystonia. So you can see these little guys. These are CRPS. So if you have CRPS, usually it will travel unilaterally or it will cross over. So it will say the pain signaling will come, and it kind of affects your big joints. So it can start, say if I hurt my finger and my finger goes to knuckle pain, which goes to wrist pain, which goes to elbow pain, which goes to shoulder pain, which goes to hip pain, go to knee pain, go to ankle pain. It stays on my right side. That is CRPS. Or it can go from I hurt my right finger and now I have knuckle pain. Well, it's my right wrist. Now it's on my left wrist. So it seems it jumps to the same, like I said, it stays unilaterally, or it can cross over bilaterally, and it can go wrist to wrist, elbow to elbow. And it kind of attacks those major joints. After it attacks the major joints, sometimes it can then go into more of a visceral piece to where people, their stomach will hurt. And it's just more general and diffuse. Some people won't have the joint pieces. It just goes general, right? And those are more your fibromyalgia type people. But then also you'll see CRPS can also kind of attack the vascular system with like POTS. So people, if you've never been around POTS will put you on your toes. So when people get tired and they have POTS, you'll do their vital signs and their pressure will be like 50/20. Heart rate will be like 26. They're talking to you. They feel fine. They feel like this all the time. Sometimes when they get tired. And then, if you treat them for a pressure of 50/20, or you don't treat them, when they start feeling better, you do their vitals again. And that's when you'll see their systolics 210. So it'll be like 210/100. And then you'll see a heart rate of like 180. So they go into like SVT all of a sudden, and they're just like, it's almost like the vascular system doesn't know how to auto-regulate itself, and it's exhausting. But yeah, ketamine helps with those guys too. So it's overstimulation, understimulation is, and the brain just gets off track, and literally these people are living in a very hellacious state. So the more we can recognize this and we can see it, then we can effectively address it. So your ketamine mechanism of action for chronic pain, you have your NMDAR antagonism, which blocks the normal excitatory glutamate signaling in the voltage sensitive calcium channels. It also binds to dopamine, D2, 5-HT2, and then muscarinic receptors. Your muscarinic receptors are the ones that help to autoregulate your acetylcholine, which was why when you have people who are paraplegic, quadriplegics, any type of paralysis, you'll see that change because it looks like ketamine's working on the muscarinic receptors, antagonizing those guys a little bit. So, it binds sodium channels. They're looking at that, similar to lidocaine, which inhibits the neuronal potassium channels. It binds to opioid receptors. So you've got your mu, your kappa, your delta. But it has no pain signal modulation there. So it actually helps to decrease the opiates that people are intaking. And then also, with naloxone, it has no effect with that. So because it doesn't work in that capacity. It inhibits inflammatory signals, which decreases cytokine release. So if you look at cytokine storms, ketamine actually can stop the cytokine storm. And then it blocks afferent signals from the ascending spinal reticular pain pathways without modifying the conduction of the spinal thalamic pathways. Sorry, I've got my 13-year-old hound dog here who's letting me know he's here. So ketamine's mechanism of action for chronic pain, you get a maximum analgesic effect observed between 48 hours and 2 weeks post-infusion in multiple studies. The magnitude of pain reduction remains significant until 4 weeks post-infusion, with some effects seen as far as 8 to 12 weeks out. So it's auto-regulating that the data systems. But what we have to do is we have to help to break the chronic habitual cycles, right? So every time we get an infusion, that's your time to intervene to try to maintain the conscious thought process with all of this. So in neuropathic and inflammatory pain conditions, topical ketamine can alleviate pain by downregulating the upregulating NMDA, AMPA, and kainate receptors. Hopefully I said that right. Case studies also support the use of ketamine as a third-line agent for intractable cancer pain. So ketamine's great for palliative pain as well. And you can see there, those infusions per day, 1.5 mg per kg per day, reduce the daily total morphine use by 50% after patients were sent home with ketamine and morphine pain pumps. So your fundamental summary here is depression, anxiety, PTSD, and chronic pain. They are all complex, multifaceted, multifactorial issues that have been proven to be very difficult to treat, with consistent, sustained, high remission rates. They involve common cerebral neuroprocessing centers, all affected adversely by chronic stress, which is hyperstimulation, oxidation, etc., causing decreased functional synaptic transmission and eventual structural atrophy. Your common behavioral psychological sequelae are fatigue, brain fog, emotional ability, anhedonia, etc., which result from these maladaptive structured changes. And so here's your fundamental summary. Traditional monoamine-based AD approaches only have about 35% success rate. So this is all very chemical imbalances. Ketamine infusions have consistently shown to have 70% plus success rate in achieving symptom remission. You just have to be able to support the person as well as the condition. And you have to, some people believe in therapy, some people don't. If you do not have effective coping mechanisms and you don't have those development up, then you should seek therapy with them. Should you have effective coping mechanisms and you understand, oh, well, this is the next step I need to take. Of course, this is the next step. Yes, I can feel out how I can take this next step. Then you should be fine without the therapy piece. The issue with chronic mental health and chronic pain is we forget coping mechanisms because we're just in survival mode. So we don't really know how to understand or how to effectively implement, integrate, and create, you're right, the system that we need. We just know that we're in the storm that we want to get out of. So if you feel like you're in a storm and you want to get out of your storm, ketamine psychedelics help that. But then you have to integrate all of those different pieces in order to create a healing environment. And this little video, if you want to watch it, it is from Yale University, and it's amazing. Put it on here, but I don't think I can play it. But if you type in Yale, you can see this picture here. Yale gives a really, really good summary as to kind of what I talked about on a pretty high level. So here's the references. So I appreciate you listening to all of this. And should you have any questions, please feel free. You can always reach out. My emails, I have several. One of them is kwalker@metrodrug.org. I also have Kathryn Walker @revitalist.com. And I will put, actually, I'll add a slide here to put this on to where you can contact me directly. But should you want additional information with this, I'm happy to come in, happy to help with help train your staff, all these different pieces. So appreciate you being here. Thanks for listening. Hope you have a great day. Bye-bye.